Hi there, good afternoon. Thank you for joining us on our 5th webinar over the past few months. So this is going to be on rigid endoscopy, or an introduction to rigid endoscopy. First of all, I hope everybody is keeping well. Flexible endoscopy. Good start. Good start. Yes, so I hope everyone's keeping well. Happy Thanksgiving to those of you listening in the States, and grateful to Nick for joining me here. And so flexible endoscopy, I get flexible, I got it right that time, is it's not a commercial area for Surgical Holdings for our business. However, it is something that we've had a lot of inquiries about in terms of interest in it becoming a part of sterile services, and obviously under the sort of decontamination banner. So hopefully this session will be useful to everyone. We're going to take, if you want to fire across some questions as we go through, please do, and we'll try and pick them up and answer them as we go through the presentation. And I'm also running a poll. You should see hopefully a tab for polls. If you wouldn't mind answering, it's just really to pick up any interest for further sessions like this, and what the subject matters may be, or what you may be interested in. Or you can just put it on the questions or the chat, whatever you wish to do. So I think we're more or less ready to kick off now. I think we've got most of the attendees in the session. So I will click off, and I think Nick and I are probably going to just block off our cameras so you can get a full screen of the presentation rather than having to look at us. Anything else, Nick, to say before you wanted to kick off, or are we ready to go? Yeah. Okay. Great. Well, welcome to an introduction to flexible endoscopy. Nick, take it away, please.
Thank you. Well, hello everyone, and as Dan said, to those of you in the States, happy Thanksgiving, and to those of you in the UK, happy Thursday, as we call it over here. Not really anything other than a normal Thursday, and looking out my window, it's quite dark and dingy, but the positives is that Zoom are doing free Thanksgiving calls today, so if you maybe have that weird and wonderful family chat to celebrate it all. So, introduction to flexible endoscopy. As Dan said, this isn't something which is really a commercial issue with us at all in Surgical Holdings. So we don't repair the scopes, we don't sell the scopes, although I believe Dan's had a few offers of agencies of them. But anyway, looking on to this. So first of all, going back, sorry, the PowerPoint has decided to go on for me, which is very good. So first IT, 2 slides in. Thank you, IT. And it's still doing it. What is endoscopy? Look inside. Oscopy is from skopos in Greek, which is a watcher or a lookout. Endoscopy, look inside. I actually, prior to this presentation, just had a Googled oscopy and endoscopy and got a rather simplistic response, which was endoscopy using an endoscope and oscopy using a scope. There are 2 types of endoscopes, this flexible and rigid. Flexible are generally through God-made openings, and rigid through man-made openings. Let me just see why this is doing this without me doing it. I don't really understand that, but there you go. This certainly wasn't doing it in rehearsal prior to this. So flexible.
Nick,
yeah.
Nick, sorry to interrupt. Did you want me to pause a sec so you can have a quick look at that, or it seems to be working right on the screen, by the way?
Well, I think I just keep going back. Okay. It's
okay, so it's obviously trying to get rid of you quickly. I think that's
which I totally understand. No, hopefully it's overtaking on manual.
Okay, go for it.
Right, so endoscopes, I think, really used to be straightforward. You had flexible and rigid. So this is a flexible scope up here. You can see there's an eyepiece on this one, so this means it's a fiber optic instrument, and they're generally these were diagnostic and these were therapeutic. The diagnostic flexibles were used in endoscopy, and the rigids were roughly used in theatre. So it was really a relatively black and white thing, and now it's really grey. To use an example, this is a semi-rigid instrument, which is a flexible tip laparoscope, and so it has a bending section like a flexible instrument, and instead of a normal telescope, as you be aware, will just come in down, it'd be a rigid straight rod with a 0 degree or a 30, usually 30-degree field direction of view, and this is flexible. It will move around, and so you can go behind a structure and look back on it, or under it and around it, etc., etc. So that's a semi-flexible instrument. And then on the other side, the development through flexible endoscopy. This was an example of what's known as a NOTES procedure, which is natural orifice. It's transluminal endoscopic surgery, but I won't go into the acronym. But it was something which took off in the States probably about 10 years ago. Didn't take off because of the technological problems. This was an example of taking out a gallbladder. You can see the gallbladder here through the stomach using a flexible instrument. So that was weird in one point. It illustrates some of the grayness that is now there, rather than the original where you just had a diagnostic flexible instrument, or this is a resectoscope for urology. So flexible endoscopy, looking at the instrumentation, we have a variety of things. There's the endoscopes themselves. This, you can see again, there's an eyepiece here. This is a fiber optic instrument, and there isn't an eyepiece. This is a video instrument. So these are two GI instruments. There are video systems to take images from these scopes and put them on, either by using a camera on the top of this eyepiece or using a video system. There's endoscopic ultrasound. This is a picture through the ultrasound picture through an endoscopic ultrasound scope. There are some scopes. This is an example of a colonoscope with magnetic coils inside that you can then see how it's looping inside the patient and get rid of loops. There are flexible accessories, weird and wonderful instruments for grasping, cutting, dilating, energy devices ranging from complex diathermy to lasers, and then cleaning and disinfection systems. And so there's an awful lot of instrumentation technology surrounding this. We really don't have time, so it will just be endoscopes. So looking at endoscopes, flexible endoscope construction is really, so it's still doing it. So I'm just looking to see what options there are. I'll pause it and see, then go from that. Flexible endoscope construction, think of it in three aspects to the instrument. There's an area for the hands, an area that goes in the patient, and an area that goes into the light source and video processor, so the handpiece, the insertion tube, and what's usually known as the umbilical, but in some countries and with some instruments it's termed the universal. Obviously inside the scope there has to be an optical system to get the image back. It's usually either fiber optic or video. Light guides, you need to get light down to the area that you're looking at, because there's obviously no natural light. That's usually using fiber optic technology. And then you have a bending section at the tip of the instrument, which uses angulation wires to flex it, either 4-way or 2-way. And then a series of channel systems inside, which are, there's channels for air, channels for water, suction, biopsy, and there can be other weird and wonderful channels, such as auxiliary channels and channels for razor bridges, which are, razor bridges are levers at the tip of the instrument for moving accessories and directing accessories. To look at a diagram of, put that in context really, this is obviously the handpiece. This is the insertion tube that goes into the patient, and this is the universal or umbilical that goes into the light source or the video processor. The distal tip has a bending section, so this is a bending section rubber here that this flexes in this situation 4 ways. You can see there's 4 angulation knobs here, up, down, and right, left. This is actually a typo. Obviously, this isn't my. I got this off the internet. There's 2 right, left. There's an up, down, and there's a right, left. Then you have a number of valves: biopsy valve, air, water, and suction, and internal channel systems, which I'll come to shortly. So that gives you a feel for the instrument. Sorry, go on.
Tony, I was just going to say, so obviously for the light, where with the flexible scopes, where obviously you've got the fiber optics for the light, is it exactly the same principle really? Is it, because obviously that understanding that they're, that's very delicate in itself, isn't it?
Yeah, I mean, there isn't a separate, with a rigid instrument, there's a separate light guide cable, which this obviously has it all integrated. And the light guide, you can see the light guide here. Generally, it is a fiber optic way of getting light to it, and so it's something very similar to a fiber optic light guide cable, not a liquid light guide cable, obviously, with the rigid instrumentation.
Sure. Okay. Yeah.
Internally, it's as you can see from this slide, really quite complicated. You have outer covers and holding this and giving obviously the handling characteristics of the scope, and then inside you've got a series of channels, and there's, as you can see here, there's four-way angulation. So there's 4 lots of angulation wires. There's a light guide for the light, a wire for adjustable stiffness, that's highlighting a particular scope, which is a colonoscope that has variable stiffness. And that was something which I actually got involved with many years ago. To give you an example of the complexity of the insertion tube characteristics, from first concept of getting variable stiffness in a colonoscope to pre-production was around 10 years. So these things are really quite complicated. Then also you have a suction channel, air and water, and CCD wires in the case of a video scope, and a coherent fiber bundle taking the image in terms of a fiber optic scope. So a lot in there. And if you think of an endoscopic ultrasound scope, for example, you'll then have a channel in there to take the wires back from the ultrasound transducer. So you're packing a lot into a given outer diameter. The internal channels, this is the most simplistic, where you have an air water and a biopsy stroke suction channel. You can see there's the biopsy valve here, the suction valve up here, and the air water valve. So all these channels have to be cleaned, brushed, flushed, disinfected. So the internal structure from that perspective is quite different from a rigid instrument. So what about design criteria for producing an instrument? Obviously, the first thing is how big do you want it? If you could get a 3-chip camera into the colon, you'd be getting very good pictures, but you wouldn't be able to get a 3-chip camera into the colon. So you need to define how big your outer diameter is, and then decide what you want to put into that diameter. What field of view you want, sorry, what direction of view you want in terms of a straightforward 0 degree, a forward oblique viewing, or a side viewing scope, which we'll come back to shortly. You need light for illumination, as I've already said, and then what kind of imaging do you want? This is white light imaging, which is standard imaging. There are NBI, narrowband imaging. This is autofluorescence imaging. So there's lots of different types of imaging through these scopes now. Whether you want it primarily for diagnostic purposes or therapeutic purposes, that will define how many channels you want, what size they are, and then obviously simple things that are obviously extremely important: how cleanable is it, how serviceable is it, and then overall, how much does it cost? As you can imagine, these are high-tech optomechanical instruments, which really are state of the art. I mean, they take around about a month to make, and so they're expensive. I mean, a state-of-the-art colonoscope, you could get a very nice car for the price of a state-of-the-art colonoscope. To put that in a bit more context, if you imagine this is the looking face on the tip of the instrument, so this is the outer diameter. So depending on what size you want, it's then a compromise of how much you want to devote of that given area to imaging and how much you want to therapy or channels. This is the objective lens at the tip. There's usually 2 headlights which provide the light, a water nozzle to flush any gubbins off the objective lens, air and water, and then the instrument channel. And that instrument channel, you might decide you want 2 channels, you might just want a very large one. I mean, there is a scope called an XT scope, which has a 6mm channel for suction. for upper GI bleeders, and that in context would, you'd have a channel something like that. So how you design your scope really does depend on exactly what you want to do with it and what compromises you're prepared to give up in terms of that purpose. To give you some actual examples of that aren't diagrammatic, this is a twin channel scope. So you'll, oops, thank you very much, IT. There are two channels here. This is the objective lens. Those are the headlights to provide the light. Again, that flushes the distal window here. And then to give an example of another scope, this is actually a duodenoscope, which is a side viewing scope. It actually looks slightly backwards, but and then, so this is the objective imaging area here, and then there's a channel here, and this is a razor bridge. So this is what I alluded to earlier. This moves in this direction and will move your accessory to target wherever you want to put it.
So Nick, sorry, that's razor, not spelled as in razor, like cutting razor. It's to raise. Yeah.
Razor bridge, similar to an Albrand lever in urology for those of you who do urology. So it's really a way of targeting the accessory that goes down the instrument channel better.
Because there's quite a fair difference between two terms, and if you hear razor bridge, thinking it might be something that requires sharpness, or so that's really emphasizes the importance of understanding this terminology, doesn't it? Yeah.
I mean, it's razor as in raising.
Yeah.
It is a strange term, but it's stuck. Okay, this is, I mean, this also has a razor bridge in it. This is an EUS scope. This tip here is a curvilinear ultrasound transducer, and then you've got the forward oblique viewing imaging area, optical imaging area, and then this is a channel with a razor bridge for guiding a needle in a technique called FNA, or fine needle aspiration. So you're effectively taking a biopsy using a targeted approach with a high frequency ultrasound. The benefit of EUS is you can use, because you're close to the organ you're looking at, you can use a higher frequency ultrasound, which gives you better resolution. So the higher the resolution, the better the the higher the frequency, the better the resolution, but the poorer the penetration. So when you're doing abdominal ultrasound, you have that fundamental compromise, and the EUS gets over that. So that's why this has taken off. And then you have weird and wonderful instruments like this. This isn't a commercial instrument. It was designed for notes, so that natural orifice surgery I mentioned before, but I used it really as just an illustration of some quite elegant design in terms of these arms come out, and you've got internal channels here for better triangulation for the clinician or the surgeon in terms of using a hook and some graspers. There could be a laser fiber coming through here. This is the objective area. This is the lens and the light area. So, quite an elegant design for something which is really looking at more therapy through a flexible instrument, which to me will definitely take off. It just, notes didn't take off, but more therapy through flexible endoscopes, I do believe will continue to be developed. So that's the scopes. Let's look at some procedure examples, and these are obviously just simple. Those are a list of a series of, these are upper GI, the first until enteroscopy, gastroscopy, colonoscopy, ERCP, EUS, and enteroscopy. Gastroscopy, obviously looking at the stomach. Colon, looking unsurprisingly at the colon, the other end. ERCP is endoscopic retrograde cholangiopancreatography. That's a way of looking at the biliary and pancreatic ductal system using fluoroscopy, a combination of endoscopy and fluoroscopy. Endoscopic ultrasound, I've already mentioned. Enteroscopy is really small bowel endoscopy. And then I've also listed some other flexible endoscopies here that aren't GI. GI is obviously the major proportion of an average set of endoscopic procedures in a hospital, but bronchoscopies are obviously very common, as are flexible cystoscopies, and then upper tract into the ureter and the kidney. ENT in nose and throat particularly, and in gynae there are flexible hysteroscopes, And also in anaesthetics, there's a scope designed to assist anaesthetists with difficult intubations.
So Nick, sorry, just obviously where you've got rigid cystoscopes and hysteroscopes as well, what would be the reason for choosing flexible as opposed to using the rigid variety?
Principally for, obviously, I mean, at the risk of sounding simplistic, I mean, it's patient comfort. There can be advantages and disadvantages of both, but to use the cystoscopy example, having a flexible cystoscope put into your urethra is a lot better than having a rigid cystoscope put into your urethra, and a rigid cystoscopy would normally be under GA. This IT is still forwarding for me, which is fascinating. So I will just have to keep playing with the this.
That's all right. It just looks like you don't know what you're doing with the PowerPoint. That's fine.
Yeah. Right. So to go through these reasonably quickly, gastroscopy, obviously looking at the stomach, but also the esophagus. So the patient will swallow the instrument, go into and the proximal duodenum, and you'll get pictures, something like this. This is an ulcer. Colonoscopy, that's a healthy colon picture. And I think colonoscopy is a good way of really illustrating how flexible endoscopy has come on from diagnostic. It's now, if you with cancer, if you manage to get cancer at an early stage, it's very curable in colorectal cancer. You obviously want to get it at these sort of stages rather than here. And putting a flexible endoscope in at an early stage, you could then put in an EUS scope, see how far in the tumour has gone into the wall, and then take it out there and then. So we're lucky enough in the UK to be in a country that has a colorectal cancer screening program, and so you could be a asymptomatic patient getting one of those screening colonoscopies. They see something at this sort of level and then take it out. And the way they would do that would be using a technique called EMR, which is endoscopic mucosal resection. That's a diagrammatic illustration of that. So you'd go in with a scope, you'd find the area that you actually want to take off, put a needle in, inject fluid, usually with some dye in it. You would then raise that area that you want to take off, snare it, remove it, and then you end up with a scar, which I'll show you shortly. So that's an endoscopic picture. You can see this is using indigo carmine dye. So you can see this is the blue fluid that has been put in to raise the area that you want to take off here. You take that off with a snare, and then you're left with something like this. So that could be done at a screening colonoscopy, and you've sorted that problem very early. ERCP, I've mentioned earlier, stands for endoscopic retrograde cholangiopancreatography. You're using a scope. If you remember, the duodenoscope is a side viewing, slightly backward viewing, side viewing scope, which is really to look at the pillar here, the ampulla ovata, and then you put a cannula in, inject dye, and then see what's going on from a fluoroscopy perspective. And you may then place a stent in the case of cancer, or you may go after some stones if there are some stones that have been come down the gallbladder and lodged. Obviously, as they lodge here, they'll cause a backlog of bile, and the biliary system will blow up. If you get it here, then the pancreatic ductal system will also do that, and you'll get some acute pancreatitis as the pancreatic juices start to sort of self-digest the pancreas. To put that in context with actual pictures, that is the fluoroscopic picture. This is the scope, obviously, with side viewing here, and this is the dilated biliary system. This is a gallstone that's gone to the end of the papilla, causing the blockage, and that will then be taken away to deblock it. EUS, this is in the upper tract. So this is an example of a curvilinear FNA scope, so fine needle aspiration. So you identify an area you want to look at, and then go in with a needle. Looks something like this. So this is the mass you want to sample, and then this hyperechoic line here is the needle going in. The needles are now designed to reflect ultrasound much better, so you can see them much better in the tissue. So you'll take a sample out and then send it on to pathology. So that's the GI area. The other areas I just want to sort of briefly highlight. In urology, you've got cystoscopy, which is there's a lot of flexible cystoscopies used, and you'll use a flexible system, or you can use it for the upper tract and go into the ureter and the kidney. Oops, sorry. Don't you just love IT? So it would be introduced into the urethra, go into the bladder, into the ureteric os, through there, up into the ureter, and then potentially also into the kidney. If you get in a very similar situation to the ERCP example I just gave, you get a stone that falls down here, you'll again get backlog of fluid, which obviously in this case is urine rather than bile, and that blows up the kidney in a condition called hydronephrosis. This is a fluoroscopic view, again the scope, end of the scope here, the stone here, and then on the endoscopic view, you'll see this is the stone, quite a beautiful picture of the stone there in the ureter. You'll go in with a laser, bash away at the stone, and then grab the stone fragments and remove them and end up with a nice clear ureter. So again, quite an elegant technique. So bronchoscopy, this is an example of a tumor in a bronchoscope. There is some movements of more therapeutic areas of bronchoscopy with placements of stents and valves for emphysema and things like that. But in general, it's more of a diagnostic technique. But again, you get some beautiful pictures through the scope of that's the main bronchus there. So what damage can be caused? That's giving you a bit of background in terms of the scopes themselves and procedures they're used for. Damage, as with everything, can happen. It can be mechanical, it could be just due through general wear and tear, it could be through extreme damage due to shock. Obviously, the tips of these instruments will swing as you move them around, and you quite often see a distal tip swinging and hitting a hard surface, or where it's put into a container for transport or storage, it may be trapping the insertion tube in that container. And as there are a growing number of therapeutic devices through the instrument, there can be damage to the internal channels particularly, or the distal part of the scope from a laser, for example. A good example, I think, of that would be the flexible ureteroscope that I just showed. If you had that in a U right at the tip in the kidney, and then you then pass a laser fiber down to start chipping away at the stone that you're looking at. If you've got a sharp laser fiber going through a U bend in an endoscope, obviously it may then puncture as you're passing it through. There's also been many instances of lasers being fired inside scopes, and obviously that leads to significant damage in the internal channels. And the thing that you really want to avoid and not get involved with is fluid inside the scope. There can be chemical damage. Disinfectants, as highlighted here, the disinfectant designers need to kill bugs but not harm humans and not harm the materials in the scopes. That's not an easy thing to do. There is some autoclavable and single patient use endoscope, flexible endoscope technology, but it is difficult to design and create something at a reasonable cost that will do the job, but well enough, but not be too costly. But overall, if nothing else to remember from today, avoid fluid ingress. And the reason for that really is, to use my diagram that I used earlier, with everything that's in there, if, for example, you do compromise that channel with a laser, that green channel, the laser fiber will come through, make a hole here, and then as you clean the scope and put it in high-level disinfectant, disinfecting for high-level disinfection, it will remain in there for a while, fluid ingress into here, and if it goes down to the tip and blows the CCD in a video scope, that can be an extremely costly repair. So,
Nick, sorry, just to interrupt. I think you've probably covered it, but question from Hank Bouch, from Beyond Clean, who we both know, just around Hank's just said, outside of infection control issues, what are the most common device failures related to flexible endoscopes? I know you probably more or less covered those, but it sounds like obviously moisture ingress is the thing to avoid.
Simple things will be things like blockages in the channels, so they haven't been cleaned potentially properly. You get air water channel blockages, things like that, or a variety of things. I mean, I've had in my former life, I had many, sorry, still doing it. I had many situations where it was simply just on these monitors here, there's line inputs, and the cleaner had changed the line input from one to another. And as a result, it was a blank screen, and I was getting an emergency message to come in to say help. So a variety, difficult to actually.
Is that you blaming IT again?
No, in that situation, it was usually the cleaners dusting these areas and then pushing, the line A or line B rather than the other one. So, but a variety of things. But I mean, channel blockage is a pretty standard one.
So what would that be? Brushing? Would that be a sort of brushing technique, or using the correct brushes to clean those?
Yeah. And obviously another one which we haven't spoken about at all is if your washer disinfector breaks down, that can cause huge problems. And again, they're mechanical things. They've got nasty chemicals in them. They will break down at some point in time. So.
Great, thank you.
So to summarise, they are high-tech, complex, very sort of state-of-the-art in terms of what you can get inside an instrument of that size. Optomechanical instruments, you need to have very good optical technology, but you also need to have very good mechanical technology to get the tip of the instrument into the area of the body that you want to get it into. The best example of that is probably colonoscopes. The cleaning is not anywhere near as simple as rigid endoscopes, as we just discussed. These instruments can be expensive, and care and maintenance is therefore important. I'm now waiting for my lovely IT to forward on the scope, and I'll do it myself. They're all breakable. What you want to really avoid is fluid ingress, and minor repairs can be hundreds of pounds. Major repairs can be extremely expensive and a high proportion of the instrument cost. So major repairs are the ones you want to avoid, and most of those are involved really with fluid ingress, and that's what you avoid. So another key takeaway of this is use your endoscope supplier for care and maintenance training, and that will help you prevent those expensive repairs. And the last thing is a quote that I've used before, which is on that line: intellectuals solve problems, geniuses prevent them. It's really about prevention of expensive repairs from that perspective, and it will save your unit a hell of a lot of money on their revenue budget. And that's it.
That's great. Got a question from Claire just come in. If only air and water go down the channels, how do they actually become blocked?
Well, air and water you can still get, if I go back to hopefully this won't forward it onto me. At the tip, you can see that these two join, and you may get some material in here that will stop it. So you'll block it usually here.
Great.
Ingress of bodily fluid, shall we say.
Okay, excellent. Is there any more questions? I think Nick's concluded the sort of formal presentation now, but we're happy to field some questions now. So please type them in on the panel if you have any. But overall, Nick, I think obviously it's very, very clear to me, and I know not too much about flexible endoscopes, but the complexity of them for me means that, obviously preventative maintenance is a must, isn't it? Making sure that you're regularly checking the scopes, and I know you mentioned about training there, but utilising training as well, really key to make sure that everyone knows the expectations for making sure the scopes are cleaned and how they're cleaned, I suppose.
Yeah. Yeah, and also I think one of the the key sort of things is that channel system that I've just shown is a standard channel system. There can be more complicated scopes with other channels that will make it. And again, you have to obviously look for those channels and brush them accordingly and flush them accordingly. It really is knowing the instrument that you're getting and how it needs to be reprocessed. And that again, that the company that provide those will provide the training. I mean, certainly the company that I used to work for has in the UK has a team of people that do that.
Great. Okay, and Claire's just follow up with another question. And also, what's the main way that fluid ingress can happen?
Fluid ingress, I think, is, I mean, again, I'll try and go through this without it going on for me. One of the classic situation, it depends on the level, the type of instrument you have, is leaving a cap off. This is the connection to the video processor, and there is a cap for that, usually with most instruments, older instruments certainly, and some of the newer ones you don't need that. But leaving that off and then putting it into the fluids is a classic. Very simple thing to do, and you just forget. And then obviously the compromise is in the internal channels. From using sharp instruments through them, and if it's going through a bend like this, obviously if the instrument is fairly rigid, it can then puncture here. So a small puncture can not be noticed perhaps immediately, but it can cause a problem. So leak testing is obviously important from that perspective.
Excellent. And Brian's followed up with a question, and just around again on the ingress of fluid. Is that removed by a standard cleaning? Would you know?
No, no. If you get fluid inside, it really needs to go back to the manufacturer for sorting it.
Excellent. Okay. Well, the questions are coming in now nicely. So just one from Ian here. So with the new procedures of notes, I would assume these endoscopes require to be sterile. So notes with the natural orifice stuff, would they need to be sterile?
Yes, well, that is and it was one of the reasons I think that it didn't quite take off, because obviously if you're putting a high level disinfected instrument through the peritoneum, that's an issue that certainly some people were questioning. I won't get into the definition of sterility, but it certainly is something that was stopping that. And the other aspect, obviously, are you using, I mean, on a gastroscope you have a channel which is usually a 2.8 millimeter channel, so around a 3 millimeter channel. It's big, and the instruments that go down it, I remember seeing an early notes procedure where the surgeon was trying to cut, and he was using scissors down this channel, and they really weren't cutting very well. So there were some technological compromises with it. And even that very elegant scope that I showed, that was a prototype scope designed for that type of surgery, you're still using very small instruments in comparison to taking a gallbladder out with laparoscopically. Those you're using 5 millimeter instruments, and the largest channel I'm aware of in a scope is a 6 millimeter channel. So and obviously, so you have some compromises.
Yeah, sure. Okay, and Sue has just commented that, but we've found that water ingress has been due to putting back into the water following leak test. I know obviously you're not on that side of it regarding the decontamination, but Sue's asked if you've got any tips around that, or if that's something that should be, I guess, referred back to the manufacturers.
I would refer it back, because there's different leak testers. Some are leak tested underwater, some are leak testing with using a sort of pressure thing, and it really, it would be what the manufacturer recommends for that.
Okay, so Sue, if you wouldn't mind perhaps putting that one back to manufacturer. And if there are any other questions that come up after we finish, then feel free to sort of email them over. You'll have my details after the presentation. So Maggie has said, what are your thoughts on low temperature sterilisation of flexible endoscopes, and is it for the future? And I know this is something we touched on yesterday, and again, wasn't really the sort of the main part of the presentation. And is that something again that's really to go back to?
Absolutely, absolutely. It's not something we can really comment on because it depends on the manufacturers and of both the instruments and the way of sterilizing or high level disinfecting them, because clearly there needs to be compatibility studies with materials that are used with whatever type approach you are doing to get rid of the bugs, whether it be chemical or a variety of different things. So and that can be quite complicated.
Yeah, okay. All right, well, thank you, Nick. Give it another minute or so just to see if we have any more questions come in, and then I think we'll finish up. But thank you for everybody's attention and for logging on to listen. And if you do have a second, please take the poll, if you wouldn't mind. If you go to polls, there's just a question around what subjects you'd be interested to hear on in the future for our webinars. As I say, this is the 5th one we've done, and we're keen to carry on and do some more. So it'd be great to get that feedback. Nick, I'll just have a check to see. Yeah, okay. No, there doesn't seem to be any more questions. So okay, well, I think we'll finish up there. Nick, thank you very much. Apologies for the IT upsetting your presentation a bit, but so this has been recorded. So we'll share the recording after. I think Hank Bausch from Beyond Clean might kindly also share it through his YouTube channel as well. So, and great. Well, everybody stay healthy. Have a great Thanksgiving if you're in the States, and we look forward to speaking to you again. Thank you. Bye.
Bye.